Good morning, everyone, and thank you all for being with us very early on a Saturday morning or whatever time of day where it is where you might be. This is the first of our 3 sessions that will address 4 important and very exciting areas in kidney transplantation. Personally, very excited for this. I've been waiting for a year to moderate this session, and our 4 speakers for this session are both national and international leaders in the field and really need no introduction, but I'll do them anyway. So our first speaker is Dr. Lyle Burdine. He is an assistant professor of surgery and has been the director of both solid organ transplantation and hepatobiliary surgery at the University of Arkansas Medical School for the last 5 years. He received an MD PhD from the University of Texas Southwestern Medical Center and completed residency in general surgery in Arkansas, and then went to the West Coast to complete fellowship in abdominal transplants from the University of California, San Francisco. His research interests are focused on novel small molecule immunosuppressants. Today, he'll be speaking to us about a hot topic in transplant, deceased donor organ selection, a key component of increasing transplants. Lyle, whenever you're ready.
All right, thanks, Dr. Farouk. Special thanks to Dr. Arthur for allowing me to come talk to y'all today. He's assembled a really nice team here at UAMS. They're a real pleasure to work with. So the talk today is on deceased donor organ selection. At our center, the transplant surgeons do most of the organ selection. And it's kind of been our philosophy of sort of how do we match the right organ for the right patient to get as many of our people done as possible. So working for the state of Arkansas, my job is to sort of try to find kidneys for the residents of the state. And this is sort of our philosophy behind it. Now, first off is Far Side cartoon, and going off the beaten path is not always such a good idea to do. In our center, sometimes it's the nephrologist leading the team off the beaten path of a particular recipient that they think really needs a transplant. And sometimes it's the surgeon choosing a kidney. And the rest of their groups are often sitting back in the selection meeting asking if this is such a wise thing to do. But I think with some careful consideration and some planning, you can be safe and get a lot of these kidneys done. But the thing I want to emphasize today is that these decisions about which grafts to take, deceased donor grafts for your patients, have to be made in the context of the health environment in which you work. For example, the talk I'm going to give you today is very Arkansas centric. So we deal with the challenges that we have here in this state and try to match grafts that will provide the most benefit for our patients. It may be very different where you're at, depending on what your end-stage renal disease population looks like. So I'm going to start with the healthcare environment a little bit and start pretty broad. So, okay. Incidence of end-stage renal disease in the United States, I don't have to tell you all about this, but a couple of things I want to point out here and a few very simple calculations that sort of guide my practice and our practice here. As you can see here, Mississippi, Louisiana, Alabama, Arkansas are up there. They have pretty high incidence. About, say in the state of Arkansas, let's estimate that we have about 400 cases of end-stage renal disease per year per million. So if you calculate around 3.5, 4 million people in the state, you're talking about probably 1,600 cases a year. If we make a conservative estimate there, I would say about 25 to 30% of the patients that we see are candidates for kidney transplant. So what does that tell me? It tells me that I need to be able to get around 400 kidney transplants done a year to sort of service the state of Arkansas. We're not there. We're really not even close to there. We're about halfway, but that's the goal. That's the steady state that we need to be able to achieve to do a good job, I think. Now, another big picture here. This is the obesity rate. As you can see here, red, the dark red in particular, is bad. The average BMI in our state is around 32, 33. And I say that to bring up the point that our BMI cutoff for a living donor is 30, okay? So when you're looking at the average Arkansan as a potential living donor for your patient population, um, most of them, or at least the average one, is not going to be a candidate due to the BMI. So this, as you can see in these dark red states, is a real big issue for the healthcare system. Total poverty, 14 to 20% of Arkansans live below the poverty line. This makes all healthcare a challenge, and there's a low healthcare literacy rate, and it really, when you're trying to bring in people for living donors, it really makes it a challenge to get them off work. People are pretty dependent on that monthly paycheck to get through. So, good news though, the a lot of these states do have a very good organ donation rate. So this is kind of interesting. This shows the donation rates by state. And as you can see here, Alabama, Louisiana, Montana's up at the top. These are the amount of donors that are registered. Arkansas is around 64%. Here's the back end of that. So Texas is around 49. I'm not listing some of the more populous states. California's 47%, New York's 32%. Now, this doesn't always correlate with the amount of donors and the kidney transplant pool that you have, but it's a pretty good estimate. And, if you take anything away from this talk, really the way to increase our organ supply in the immediate future over the next decade is to really some money effort in increasing this donor registration. And so, and that is kind of all I'll say about it before we go on down the road and keep going through all these machinations with changing the organ allocation. I mean, to me, this is where we need to focus. We need to bump these numbers up as high as possible to sort of achieve those steady states that I was talking about earlier. So that's kind of a very rough and simple look at the healthcare environment in which we're working. And I'm going to sort of transition here to talking a little bit more about the graphs and the selection of the graphs. So this is an old, relatively old, mid-90s early paper by Lloyd Ratner out of Hopkins. And it just shows that, they're comparing the lifespan of expanded criteria donors. So these donors that and kidneys have a few strikes, either age or some hypertension, maybe a little bit of borderline diabetes versus a conventional donor. And we've known this for quite a while, that the expanded criteria donor kidneys do pretty well if put in the right patient. You don't see a real big difference between these two. Now, this is a really good paper that came out in 2014, also out of the Hopkins group. And what they show here is that if you select a kidney based on KDPI, it really doesn't matter if it's a high, 91 to 100, 81 to 90. The high KDPI kidneys for patients really increase the survival of these patients down the road. And so we need to not be ignoring these as a potential donor source. And I think everybody knows that, but there's always a disconnect between knowing this and then put it into practice, because when you're one-on-one with a patient, I think we're all sort of inclined to try to get them the best possible graft they can give. Now, I don't know how many of y'all saw this, but this was a really interesting paper to me. This came out in 2019 out of the Paris Transplant Group. And I thought this was really interesting for the following reasons. What they did here is they compared the acceptance sort of rates and protocols in France and overlaid them onto the United States rate. And so they show here that, and I want to, sort of point your attention down here to these C and D. And this is the discard probability based on the KDRI, which is kind of like the KDPI, another measure of kidney quality. And there is a sort of gradual upslope as you increase the KDRI, where there's almost a logarithmic upslope in the US. And so, there's a lot of opportunity in the United States between this 2 and 3 KDRI to find some good kidneys for our patients. And they estimated, that we would save, thousands and thousands of kidneys if we just adjusted our acceptance rates a little bit. And I think they're right. It's hard to prove, but I think that they're right. And so, working at UMS, I'm going to kind of show you what our stuff looks like. This is on the SRTR data sets. All of our data in transplant, as y'all know, is publicly available, so you can just look it up. But so overall, our offer acceptance, which is up here on the left, is sort of on the high end of normal. For low KDRI kidneys, so this is your 25-year-old kidney with no pre-existing medical conditions, perfect creatinine, brain dead donor. I mean, we basically accept like everybody else. Everybody wants these deceased donor kidneys for their patients. But as you get to the medium and the KDR, high KDR kidneys, we tend to be a little bit more aggressive. And I think that's really what we're doing to try to match our kidneys to, or these higher KDRI kidneys to the older patients on our list and the patients that really need to get off dialysis. Now, these are outcomes. So, we do about right now 156 to 170 a year. As I mentioned previously, that number needs to be way higher to sort of meet the needs of the state. The patients do okay as far as your survival and getting off the list fast, but you can see there's a lot of things that we don't do well that our particular center has to work on. Survival on the wait list is a big one. It's not something that is easily controlled from a transplant perspective, but there's still, despite the fast transplant, there's still a lot of people on all these lists dying on dialysis. The other thing that's really been an issue, and this is a little artificially low from COVID, but because we kind of shut down living donor transplants for a while, but our living donor transplant rate needs to be about 30% of all transplants. And I think that you'll find, in these states, that it's very difficult to find those living donors. It's kind of a challenge. So last thing is we're primarily a majority minority transplant center. Over 40% of our patients transplant are African American, and just fits with the demographics of the state. So backing up, when we take these graphs, probably the most important thing to me is the biopsy. And I'll kind of use this as a plug for Arcana or any of the pathologists out there. There is, and I'm sure y'all know this, there is an extreme amount of disconnect between pathologists and how they read these biopsies. This is a paper out of 2017, AJT by Lapis, where it's really good because they show that although the pathologists generally agree on the glomeruli and the percentage sclerosed, there's a lot of disagreement on like ATN, how many of the gloms have thrombi in there. One for me that's particularly concerning is the hyalinosis. That's something I like to look out for, but it's hard to get pathologists to agree on that. And so I think one thing as we move down the road in transplant is that we need to figure out how to find a uniform read on these kidneys to prevent unnecessary discards. Speaking of glomerulosclerosis, this is a paper by Gaber in the mid 90s. And you'll hear a lot of, I don't know if some of y'all take organ offers at your center, but with us, you'll hear a lot of the 20% glomerulosclerosis rule. And the reason that's the case is that this comes from this paper where what they found is that once you get over that 20%, the mean serum creatinine goes up. Now, I'm not saying that every kidney with glomerulosclerosis over 20% is not usable, but as a hard and fast rule, that's generally what we do. And this is the paper that it comes from. It's not a huge sample, so it's an area that we probably need to research to figure out what other factors are affecting sort of this suboptimal function of these kidneys with a higher sclerosis rate. And y'all know these candies. These are like the least favorite candies in my house with my kids. But I don't care so much about what the biopsy looks like now. I mean, if it looks okay, it looks okay. What we really care about is, what does the biopsy look like in 6 months? What does it look like in a year? What does it look like in 3 years? How do we optimize care of these grafts, especially these extended criteria grafts, to prevent the scarring and the fibrosis that goes on? How do we optimize the immunosuppression? How do we get, I'm not a huge fan of protocol biopsies at a relatively resource limited center. They're kind of expensive, but how do we get, either a liquid biopsy or a protocol biopsy to tell us sort of everything we need to know down the road to optimize and sort of squeeze all the lifespan that we can out of these grafts? Again, I'm going to shift gears here a little bit. Going back to the donors. This is a paper by Klaus Niemann out in the New England Journal of Medicine in 2015. Really interesting. And what they found is that if you, prior to procurement, lower the donor temperature 1 degree Celsius, you have a significant change in the amount of DGF that you see in these criteria. And this has gone, you can see it's 56% at normal thermia, and then it's 31% as you drop this down at hypothermia, just 1 degree Celsius. And this is surprising. I would not have predicted that. And it's something that I think we need to continue to look into, is how do you optimize the donor to preserve graft function and achieve the optimal graft function for these patients. Now, that being said, in 2000, here recently, actually in April of this year, they came out with a study in JAMA, which after the kidneys are out, if you put them on the oxygenated hypothermic perfusion machine, you don't see a huge difference in outcomes. So, this needs some more work and it needs to be a little bit more granular, but what it's telling me is that, a lot of this damage that goes on with the kidneys that we see down the road is probably prior to the time of procurement. And that may be the optimal time of intervention. But this is an area of research, and I bring it up just to put in your back of your mind when you're thinking about this stuff. So sort of the last thing that I'm going to talk about here, and then I'll open it up for questions, is the patient. And when you're doing these type of when you're doing these type of decisions, you need to think about the patient. You need to think about how the patient matches with the kidney that you're interested in. And in particular, what I want to talk about today is kidney transplants for the over 65 crowd. Now, this volume hasn't been increasing over the last sort of 5 years, 6 years, and it's going to continue to go up. I mean, I know every day when we're evaluating patients, we see more and more people with a, over the age of 65, over the age of 70, over the age of 75, and they look pretty good. And the question is like, what's the upper limit of where we should be transplanting? To me, we do a lot of evaluation. It's just based on sort of, how functional they are and their biological age, but it is something to think about, and how do we find the right grafts for these patients? Now, as you can see here, this is a really good study by Cabrera in 2020, and all of these patients are over the age of 75, and they have a 75% roughly 5-year survival with transplant. So I think that we really need to broaden it. If we can find people in their mid-70s that are in good health, we really need to think about transplanting them. So this is some work by Dr. White. She's one of the transplant pharmacists in our group. And we took the SRTR data, and this is unpublished, and looked at sort of what type of grafts our over 70 crowd need. First off, we didn't see any difference between giving them brain dead versus donation after cardiac death. The serum creatinine was the same. They stayed in the hospital roughly the same amount of time. What about the ECD grafts in the over 70 crowd? Well, those work pretty well. I mean, the ECD graph in somebody with over 70, 93% 1-year survival rate with a pretty normal serum creatinine. Now, cold ischemia time is something that we continue to battle, especially with the allocation changes that have undergone this year. Kidneys are kind of flying all over the United States. And, is there any difference between putting them in over 24 hours or under 24 hours? A lot of the different centers have different cutoffs. Our upper end cutoff is pretty long. I mean, we'll put good kidneys in up to 40 hours or so, but there's really no difference in these over 70-year-olds with a cold ischemia time less than 24 hours or over 24 hours. But here's where there is a difference, and there's some, and that is that how long are these people over 70 on dialysis? And this is where I get back to knowing your list and making decisions on graft, knowing the patients on your list. So only not, you double the chance of dying over the age of 70 if you're on the dialysis list greater than a year. So what we really try to do if we list these patients is get them transplanted in the first year with a graft that's going to give them, at least a 5 to 10 year lifespan. That's kind of what I'm shooting for. And so we take all kinds of offers, and they tend to do pretty well. So in conclusion of I just want to let you all know that this is the deceased donor kidney transplant is a healthcare environment decision. So our decisions made here in Arkansas are, really depend on the fact that we have, high obesity, high poverty rate, a lot of end-stage renal disease. It depends on our patients. We got a lot of patients over 65, and they don't do well on dialysis for a long time. And finally, we've known for some time that you can use grafts with the ECD criteria. How do we optimize those grafts, particularly prior to procurement? And secondarily, maintenance immunosuppression. The CNIs, we all know are pretty toxic, but they're still the mainstay for our patient population. It's tough to get everybody on biologics, and as the treatments advance, you got to think about the patient population. Are they going to be able to afford the drugs? Are they going to be able to travel in and get the transfusions? Cell-based therapies, that's a big lift for centers like us. So, there's a lot of opportunity for research there. And that's kind of all I got. And I'll quit sharing and answer any questions if anybody's got anything.